Hello and welcome to another NANSIG video series. My name is Conor. I'm a medical student at the University of Liverpool, and today I'm going to talk to you about eponymous syndromes. This is going to be a two-part series, with part one, this video, being just for cranial syndromes, and part two, which should hopefully be uploaded at the same time as this video, we'll be going over the peripheral nervous system and spinal eponymous syndromes. And just a brief introduction and some learning objectives for this video. The best way to introduce eponymous syndromes would be to say that individually they're very rare, and you're actually, as a medical student, really unlikely to encounter these in clinical practice. However, it's been highlighted to me that there are so many eponymous syndromes out there, specifically for neurology and neurosurgery, that cumulatively they're really not so rare, and actually you are very likely to encounter perhaps one or two of the mentioned syndromes that I'm going to discuss at least once or twice in your career. And that's why the goal of this is to develop a little bit of knowledge about each one. And I think that in-depth knowledge, more specifically about some of these syndromes, the in-depth pathophysiology, and especially regarding management, it's only really required by specialists and those that are particularly enthusiastic about neuroanatomy. And a really good way to use this video is specifically for those in the younger years. You can actually use these rare eponymous syndromes to demonstrate your knowledge about anatomy and neuroscience more generally, as they're really good in explaining how the brain works, and you can think of it like that and always go back to that anatomy. It's going to be almost a list this first video, and that is just due to the fact that there's not really much of a better way to go through it, but hopefully we'll keep it short and sweet and get some pertinent knowledge by the end of the video. So the first syndrome is a classical medical student exam syndrome. This is Horner syndrome, and unless clinical medical students have been living under a rock for the last 2 or 3 years of their training, Horner syndrome is a classical clinical triad of miosis. This is a constricted pupil, partial ptosis, meaning there's an eyelid droop, and apparent enophthalmos. This is posterior displacement of the eyeball within the orbit. This is the opposite of exophthalmos, which is anterior protrusion of the eyeball outside of the orbit, which is found in hyperthyroidism, specifically Graves' disease. You can also get a ipsilateral anhidrosis with Horner syndrome, which is just a lack of sweating on the affected side, wherever your lesion is. With Horner syndrome, it's a really good example of the anatomy in the fact that there's so many different locations for pathology to cause a Horner syndrome, and it's really all to do with the innervation and just the general direction of the sympathetic nervous system tract, as the sympathetic nervous system tract is responsible for this syndrome, as it dilates the pupil, as it is involved in innervating muscles that elevate the eyelid, and damage to this trunk, any structural damage or infarcts are going to give this syndrome. More classically, the cause of Horner's would be a bronchial carcinoma that occurs at the lung apex, and this is known as a Pankos tumor. However, you can also get it caused by a carotid artery dissection. At this point would be in the neck, and it can also occur after a pica artery infarct. So you can see there that damage to the sympathetic trunk could occur almost at the lung apex with the bronchial carcinoma, in the neck with the carotid artery dissection, and in the brainstem with the pica infarct. And this is due to the fact that the sympathetic nervous system trunk travels down into the neck and then back upwards into the brainstem. With regards to investigations, it's all about looking for that primary cause of your Horner syndrome. So go after the Pankos tumor in the smoker, and go after the stroke symptoms and the stroke in the individual with the carotid dissection. With regards to specialist investigations, you can use topical cocaine eye drops. It's an interesting anatomical and physiological experiment, really, because it blocks the reuptake of noradrenaline from the presynaptic terminal, which is what cocaine does. And this would give you greater sympathetic nervous system innervation and dilate someone's pupil if you were to do this to them. But in Horner syndrome, as the sympathetic nervous system trunk has been destroyed or infarcted, it would actually have no effect. Even if you gave them some cocaine eye drops, it would have no effect on their pupil size. And the rest of the investigations have been discussed. So we're going to move on to Weber syndrome now. This is less commonly known among medical students, but it's a favourite of those enthusiastic and interested in neuroanatomy specifically. It's defined as a superior alternating hemiplegia, which sounds complicated, but when you break it down, it is not so complicated. This merely means that there is a ipsilateral oculomotor nerve palsy with contralateral hemiplegia. So you would have the lesion, for instance, on your right hand side, and you would get a third nerve palsy on, say, the right hand side, but you'd get contralateral hemiplegia on your left hand side. The reason for this is there is infarction of half of the midbrain that occurs after occlusion of the paramedian branches of the basilar or posterior cerebral artery. It can be either. And classically, the person will have the third cranial nerve palsy. That would be ptosis because of the lack of innervation to the levator palpebrae superioris muscle that elevates the eyelid. Ocular deviation due to the lack of innervation to the 4 out of the 6 extraocular muscles, and the ones that are supplied by cranial nerve 4 and 6 would overpower it, meaning the pupil would be deviated down and out. And you'd also get a fixed and dilated pupil. This syndrome is incredibly rare, even though I personally have seen one myself on a stroke unit, and so it's always important to keep in the back of your mind. In essence, to take from this would be Weber syndrome, ipsilateral oculomotor nerve palsy, and contralateral hemiplegia. So now we're going to speak about Pick's disease, which is also known as fronto-temporal dementia. It's the classification and the naming, the nomenclature, has mostly been superseded by frontotemporal dementia, but some clinicians still use Pick's disease, and thus I thought I'd put it in the cranial section. Frontotemporal dementia is a subset of dementia, and it represents 10% of all patients with dementia, and specifically the pathophysiology is going to be prominent atrophy of both those frontal and those temporal lobes. There are a few subtypes, but for the purposes of this video, I wouldn't focus too much on them. What I would focus on is that the onset tends to be generally earlier than other types of dementia like Alzheimer's, with the typical age onset being between 45 and 65. Unlike Alzheimer's disease, the short-term memory of the patient is usually intact. This is one of the most earlier features to present in someone with Alzheimer's, and it's an important distinguishing factor between the two. With regards to clinical features, it's all relevant and pertinent to that frontal and temporal lobe atrophy. The frontal atrophy would cause you to have prominent personality change that would be not relevant and not like the individual, and the temporal atrophy would cause language disturbances. This is a clinical diagnosis and best diagnosed by either a neurologist or a memory specialist, and mean survival is 6 to 11 years. Moving on to another condition called lateral medullary or Wallenberg syndrome. This is something that is more well known with regards to eponymous syndromes, at least neurological, by medical students, and I think there's good reason why. This is a set of clinical features that occurs due to a brainstem infarction that happens due to occlusion of this vessel right here. This is the posterior inferior cerebellar artery, or PICA, and as you can see there, it arises from the vertebral artery in most people. There is some variability. The clinical features that would happen when this artery is occluded is a contralateral loss of pain and temperature on one side of the body that would exclude the face, ipsilateral loss of pain and temperature on the face, and potentially an ipsilateral Horner syndrome, although this doesn't occur in 100% of patients. So you would get the loss of pain and temperature on the other side. Say if the lesion's on the right, you'd get contralateral loss of pain and temperature on the left-hand side of the body, but you would get ipsilateral loss of pain and temperature on the right-hand side, the side of the lesion itself. You may also get associated POX, or posterior cerebral stroke symptoms from this, such as vertigo, vomiting, nystagmus, dysarthria, and dysphagia. There's a really crucial point of Wallenberg syndrome is that there's usually no limb weakness, and if you're dealing with a patient with limb weakness that people are saying has Wallenberg syndrome, chances are you may need to check and see if it is. Unfortunately, there isn't anything particularly special about investigations, diagnosis, and management with Wallenberg's. It's really just about diagnosing it and treating it according to your local stroke protocol. Now we're going to talk about Creutzfeldt-Jakob disease. This is a very rapidly progressive form of dementia that leads to death within 6 months. I believe it's one of the fastest, if not the most progressive type of dementia that one can get, and part of this is due to its very unique pathophysiology. It's one of very few conditions out there that arise due to an accumulation of something called prion proteins, which in essence are normal proteins present in the body that later develop mutations that become almost infectious, in the sense that spreads to adjacent proteins, become misfolded, and infect adjacent proteins by misforming them and changing their overall direction. With regards to CJD, it's part of this prion disease complex, and some of them can actually have a genetic element. However, most cases are sporadic. It's a very, very rare disease, and it's classed as a 1 in a million disease because it classically only occurs in 1 in a million patients, which would be roughly 60 cases each year in the UK, but I don't think there's even that much. There is a variant subtype, and this is due to the fact that it was first discovered in cows, and it was originally submitted as called bovine spongiform encephalopathy, or BSE, or more frequently known to the public as mad cow disease. The clinical features would be a very rapidly progressive dementia, particularly in a young patient. You would also get myoclonus in 95% of patients, which is a useful diagnostic clinical clue. It's often referred to as startle myoclonus, and you may also get depression and eye signs. For investigations, an MRI can show certain changes that may indicate CJD, but it's not entirely specific. An EEG is only sensitive in 60% of cases, but it does sometimes show this periodic, almost classical triphasic complexes. And the only definitive way to diagnose CJD is by a brain or a tonsillar biopsy, although there has recently been a blood test developed by a certain team at University College London in London, and we're waiting to see how effective that is. You may also want to examine the CSF via an LP and examine a certain protein called a serum 14-3 protein, as this may sometimes be raised in CJD. With regards to treatment, there is no effective treatment for this condition, and most patients are deceased at 6 months from original presentation. Our next condition is Gerstmann syndrome. This is a very interesting syndrome, and it's actually very similar to Weber's syndrome in the sense that it's not known at all by the mainstream medical student population, but to a neuroanatomy specialist or someone that's perhaps intercalated in neuro or is just particularly passionate about it. It may be their bread and butter, but it's a really interesting syndrome that I thought we'd explore. This is also known as the angular gyrus syndrome because it affects the angular gyrus part of the brain, which is in the parietal lobe. And it actually gives a really classic clinical picture of finger agnosia, agraphia, acalculia, and left-right confusion and disorientation. And really, the left-right confusion and disorientation and the finger agnosia tend to distinguish it from other conditions. The cause is often this lesion of some sort in that dominant parietal lobe, which would be on the left-hand side in 90% of people who are right-handed and in 70% of people who are left-handers. The most usual cause of such a complex odd syndrome is some type of vascular insult, such as a stroke, but it could also be rarely due to an MS plaque. The only other footnote here is to not get this confused with Gerstmann-Straussler-Scheinker syndrome, which is a genetic prion disorder which is similar to the CJD. To take what you would want to take from Gerstmann syndrome is angular gyrus syndrome affects there, finger agnosia, agraphia, acalculia, and left-right confusion and disorientation. So now we're going to move on to Wernicke's encephalopathy. This is well known by all medical students, so hopefully this should just be revision for those in the clinical years. This is an acute clinical manifestation based on a deficiency in thiamine, which is an important vitamin responsible for metabolism. The deficiency isn't common in humans generally. However, its incidence is significantly higher in those with decreased intake of general nutrients and vitamins, or reduced absorption of previous GI surgery. It's also much higher and classically seen in patients with alcohol dependence because they don't get as much nutrient intake due to the replacement of food with alcohol for the caloric intake. It is a neurological emergency, and it's marked by a classic clinical triad that includes ataxia, nystagmus, and ophthalmoplegia, and neurocognitive dysfunction, which could include amnesia and stupor. But this is sort of only this constellation of signs all occurring. This clinical triad is only present in 10% of cases, so the presentation may be more subtle. With regards to investigations, it's important just to rule out any other causes of such an encephalopathy, such as a blood glucose, check your serum thiamine, and can just make sure that there's no other cause of it. MRI and head scanning isn't usually helpful, and it's more classically a clinical presentation. And the best treatment for this is to simply replace the deficient vitamin, which is the thiamine, given IV or IM with some other vitamins thrown in there. One really salient point that I hope you guys should take from this is to avoid giving glucose with your first dose of thiamine. This is because that if you give it straight away, it will actually conversely deplete the body stores of thiamine and cause worsening of your symptoms. Now, Wernicke's is good because it's not very nice to have, but it's reversible, and you can make sure that you can reverse the patient back to their normal state, and they won't suffer any long-term damage from this. But if this is sustained for a long period of time, it can lead to something called Wernicke-Korsakoff syndrome, more simply known as Korsakoff psychosis. This is a rare form of dementia that is caused by the B1 deficiency, and is most caused by alcoholism. And I have seen a case of this in a 26-year-old male, and it's not light stuff. The pathology is that, as you know, thiamine is involved in glucose neurotransmitter metabolism. If you are deficient in this enzyme, you essentially get glutamate accumulation and cell death. The specific area in the brain that is involved in this condition, this syndrome, is the mammillary bodies and the anterior thalamus, more classically the mammillary bodies, which atrophy. The mammillary bodies, which some people don't know, is actually involved in the memory circuit, the circuit of Papes, which, if impaired, would lead to reduced memory and characteristic features of anterograde amnesia, retrograde amnesia, so not being able to remember events that have happened in the past, not being able to remember new events, and something very specific for Korsakoff psychosis called confabulation, which is a unique feature of someone that essentially, on direct questioning, makes information up and has a false perception of events, even though it's true to them. Korsakoff psychosis carries a poor prognosis when it is permanent, and it's really important to catch a patient in the Wernicke's encephalopathy stage before it evolves, as very few recover even with aggressive treatments. And this is the final syndrome in this part of the video. It's one of my favorites. It's called Parinaud syndrome. This is also known as dorsal midbrain syndrome, and it's a clinical triad that consists of an upward gaze palsy, also known as inability to move your eyes upwards, pupillary light near dissociation, and this means that pupils respond to stimuli and not light, and you may also get convergence retraction nystagmus. And that's the clinical sign, is the clinical triad is upward gaze palsy, light near dissociation, and convergence retraction nystagmus. There are other symptoms and other signs you can get, but that triad is the most important to remember. The cause of Parinaud syndrome is going to be a pineal tumor or a midbrain infarction, with a midbrain infarction being most common. So the area that is affected is the dorsal midbrain. I'm not entirely sure how the pathology of an infarction in this specific area would contribute to all of those symptoms, but it's just really important to know that Parinaud is just that clinical triad and that affects the dorsal midbrain. And really all you can do for this is go after, just like Horner syndrome, that underlying cause, the stroke or the pineal tumor or mass, and look for those and treat them accordingly. And that concludes the first part of this video. Hopefully you should be able to find part 2 just in the recommended videos suggestions after this one. I'd just like to thank you all for listening. If you have any questions, you can contact me via the email below. And I'd just like to also give a massive thanks to Dr. Rhys Davies, a consultant neurologist at the Walton Centre, who was able to review and approve the content and presentation of this video, and I'm very grateful for him. And also a special thanks to Stephen Doherty for his help with the artwork, the design, and the overall presentation, and I really want to thank him again. And with regards to references that I've used for this presentation, the biggest one is the Oxford Handbook's chapter in clinical medicine of eponymous syndromes. I also use BMJ best practice a lot, and Eureka neurology and neurosurgery. And that concludes the video. I'd just like to say thank you very much for your time, and thank you for listening.